Good evening, ladies and gentlemen. We should be starting in the next 1 minute or so once everybody has seated. It's good to have you all here this evening. Hello, can I please make a request for everybody to move forward? So if you're in the last rows, could you kindly move forward? So it will also enable people who come a bit later to just seat. Thank you. So please just move forward. We have a second row here that's completely empty. Thanks all. So some people on this row, are you able to please move forwards a bit more? Sorry to disturb your seating. We'd really appreciate that. And then we can get started. Okay, I think we can get started. I realize that all of you here this evening are giving up your very precious time. There's a very important event also coinciding with this one, but we all know how you prioritize listening to coming to our side event. So thank you for being here. And we're all rooting for Morocco. So this event, Health Communications in a Public Health Emergency Response, I think as an organization, we kind of conceptualized it as a very important topic. When we think about epidemic preparedness, when we think about outbreaks, how do we communicate to the communities? How do we communicate to everybody? How do people know what preventive measures to take? And that language we use and the importance of communications has to be part of any emergency response. We all saw how COVID-19 affected countries all over the world. And simultaneously, we had to think, how do we as individuals understand what's happening? And the role of communication was very important. So I run an organization called Nigeria Health Watch. We put this together in partnership with Sydani. My name is Vivian Ihekwazu. And this evening, we want to really spend time talking about another issue when we think about epidemic preparedness and public health in general. What role does communications play? And how do we as individuals, organizations, groups, in ourselves understand the role of communications? Because it has to be a critical element of how we respond to outbreaks going forwards. Many countries had to come up with different communication campaigns, some very creative. You'll be hearing about some of the work we've been doing at Nigeria Health Watch, as well as the case study from Sydani, on how different platforms were able to communicate, how the government was able to use messaging, how media was able to influence response, how organizations, we have Africa CDC represented here by Dr. Benjamin, how as an organization they too shaped the way we communicate. And this for us we think would be a good lesson learned so that going forwards, how do we respond to current and future outbreaks? And the role of communications has to be front and center of how we do that. So I will just welcome you once again this evening. Thank you so much for giving up your time. We hope to not spend 2 hours because we are anxious. Some people want to watch the football match. But at the same time, I hope you're able to take in what we say. There'll be question and answer sessions after each section of the event this evening. You all have programs, and that will give you an outline of the run of show. So the first topic on our program is the opening remarks by Sydney Sampson, who's the managing partner of Sydani Group. And he'll also introduce the work that they've been doing. And further on, there'll be a case study that they'll be presenting. So give a round of applause to Sydney, and he'll come and demonstrate. Thank you.
Thank you very much, and good evening, everyone. Again, thank you for coming. The match is starting in an hour or so it hasn't started yet, so we hope that within the time we have, we actually have all of your attention. So my name is Sydney Sampson, like Vivian has said, and I'm the Managing Partner and Chief Executive Officer at Sydani Group, and really excited to be here and seeing all your wonderful faces and all. First, I'll start by saying this is a very important meeting, and if we take a step back and talk about communication, first, when you look at the different organisms, animals, and you say what makes us different as a species, most times is one of the most important things is our ability to communicate, to have these kinds of gatherings, to sit together, think, see things that are not, plan things and all of that. So that is one of the biggest things that actually makes us really unique as a group of people. And one thing we also know is that when there are emergencies, which sadly happen now more frequently sometimes than in the past, there is always a lot of chaos that follows that. So when there's an emergency, especially new ones like COVID that we've never seen before as a people, there is chaos that follows. And once that happens, myths all of a sudden come alive. You start hearing different kinds of things that you've never heard before. You start seeing people do unimaginable things. I can go on and on with some of the different things we've heard. During the COVID, lick a lot of salt and you'll be fine. Drink a lot of this, bathe with this. All of those kinds of things, they come alive, and you'll be shocked at how far people actually take these things up. And then our ability to communicate, our ability to actually strategically and proactively put out the right information in a lot of ways defines how we as a people, how the world responds to this. When the COVID pandemic broke out, there was a lot of chaos. Nobody knew what to do. And at that time, different things started happening. And as they say, you can't have vacuum in this kind of space. So if you're not communicating, someone else will communicate on your behalf. And at that time, all of these words like misinformation, disinformation, and all of those started also coming out, and we started hearing a lot of that. Here today, we have come to, we've gathered to review some of the lessons and the best practices from communicating, especially in the public health response. The COVID-19 pandemic has taught us many lessons, and one of such is that we have to be strategic, we have to be proactive in the way we communicate, and in the way we drive home the right communication. In the absence of such, the wrong information proliferates, and it becomes even harder correcting those wrongs once they are out there. Sydani and Nigeria Health Watch are elated to have all of you here, distinguished ladies and gentlemen, sit with us to discuss how far we have come as a people, learning from the struggles that we faced during the COVID-19 pandemic, the interesting ideas that came up, like Vivian mentioned, the strategies, the innovations that different people from different places put in, and we came together and did a lot of different things. Nigeria Health Watch will share their lessons. Sydani would also share some of what we have done, the social listening project and all of that, to actually see how we can, as a people, prepare for future pandemics. The fact alone that we are gathered here today is a clear indication of our resolve as a people, as a global community, to be intentional in improving how we communicate, not just for pandemic preparedness, but for driving the change that we so desire in our health communities, in our countries, in our people, to driving those different strategies home. And for me, it is my honor and privilege to really welcome you all. Like she has said, we don't want to also take a lot of time. We want to get into the discussions. We want to listen. We want to share. We want to discuss. We want to see how we can build on all what we have done before. Like they say, no one knows it all. And that is why we're all here as a people, to actually see how we can draw lessons from all of what had been done in the past and actually build up. Sydani is a young organization based in Nigeria that has been, over the past 4 years, has grown to become very strategic in the support it gives to the government in Nigeria and now across a few other African countries. And we are really privileged to have this partnership and to host all of you today to this wonderful side event. You're welcome. Thank you.
All right. Thank you very much for the opening remark. I would just like to bring Kemisola Agbaoye, Director of Programs at the Nigeria Health Watch, to take the opening presentation. Thank you.
Hi, everyone. Thanks so much once again for deciding to spend your dinner time with us. I promise it will be worth your while. We're going to be sharing a bit about some of the work that we have done here at Nigeria Health Watch. Okay. So I'll just quickly run through these slides. I would not belabor what's been said already about the importance of risk communications and how imperative it is to our public health response. We know what happened during the COVID-19 pandemic and what happened during Ebola. Everyone knows about the salt and water story and how people drank and had their baths in it. And we had, at least 2 people die from that back then in Nigeria. Apologies, looks like we're having a little trouble with our slides. Yes, okay. And, with the advent of digitalization and social media, we know how quickly misinformation spreads right now and how important it is that we pay particular attention to debunking misinformation on the platforms where they spread and as quickly as misinformation spreads. Yes, I would not speak so much to this slide anymore. And Vivian already spoke about what we do at Nigeria Health Watch. We're a health communications and advocacy organization. We use informed commentary and insights to advocate for better access to quality healthcare for all Nigerians. And we do that in a number of ways. One of our strongest advocacy tools is social media. And seeing as we're here to discuss communication in a public health response, and we know how very quickly information spreads on social media, it's one of the strongest tools that we use. We also convene strategic events. We use our editorials as well. Our editorial is one of our foremost tools when it comes to advocating for better access to quality healthcare in Nigeria. And we use both solutions-oriented pieces and thought leadership articles to advocate for these. Okay, and I just wanted to speak very quickly about the Take Responsibility campaign and the Health Fact Check Nigeria campaign. So the Take Responsibility campaign was the NCDC's risk communications response to the COVID-19 pandemic. We supported the Nigeria Center for Disease Control during that time, and rumor monitoring and fact-checking was rapidly conducted at the time in order to, influence behavior change and get people to adhere more effectively to the non-public health measures that were instituted during the pandemic. And we were embedded, or we were part of the technical working group who worked on this, in collaboration with the head of risk communications who is here. You'll be hearing a whole lot more about that campaign during the panel session. But after that, we then partnered with an organization called Medan, where we actively debunked misinformation around COVID-19 at the time. And evidence was curated from the experts that they had on their roster. And we were able to rapidly put out information or debunks of those misinformation at the time. And the interesting thing about that project was, at the time, most misinformation or debunks or fact checks that were conducted were on non-health matters. They were on news, they were on, oh, this politician said this is not true, and they usually did not use non-text formats. So it was really innovative at the time to debunk misinformation using comics, using infographics, videos, and basically the kind of content that people engage with, so that while they're engaging with the content, they then get exposed to the right information. And I wanted to talk also about how that project then evolved, because right now we are conducting or basically implementing the Health Fact Check Nigeria project in 4 steps. We're conducting social listening, both online and offline. Online, we use a social listening tool, and we curate, basically we just actively listen to what people are saying across platforms, on social media, on blogs, on YouTube, Twitter, Facebook, and we curate the misinformation that we identify from that active listening, and then use evidence to debunk it and disseminate in multiple formats and on multiple platforms. And offline, we did this interesting thing where we identified community listeners. So basically we identified and trained members of the community in a state, in Niger State in Nigeria. And they then went into the communities and told us what people were saying about key health focus areas, including maternal and child health, routine immunization and polio. And we then collated that and conducted research in-house and created content to debunk them. And we put out the contents that we curated in really different ways. So we created scripts that were then aired on radio, that are currently being aired on radio. We are in the process of developing a web series, which is something that's really popular. It's growing in popularity, especially among the young or the youthful population. And we're in the process of developing an 8-minute clip from one of the misinformation that were identified from the online listening that we conducted. And what we found, or some of the successes that we've recorded from that, is that we've then, I think, so one really cool, really interesting thing that happened was the health educators that we then trained, right, for the offline listening, were really excited because they had not been exposed to a training that just focused on how they can manage misinformation at the community level. And it was really revolutionary because they then went on to cascade it to other healthcare workers in the facilities, and without any support. We did not say, oh, would give you a stipend or help with your transportation or anything. They took it upon themselves, took the IAC materials that we provided and went into the communities, trained other healthcare workers in their facilities, leveraged their community meetings and community structures to disseminate the information and say, this is the misinformation that was identified in your community. Because a bit of a backstory, we had actually conducted a bit of a survey to find out what people knew about key focus areas that I mentioned earlier. And we had identified misinformation across 3 of them, across sexual and reproductive health, maternal and child health, and routine immunization and polio. And we had then developed IAC materials to convey the debunks on the misinformation that we identified at the community level. And the health educators took it upon themselves to go into those communities and disseminate the information again. And it's still happening. So all of this just has taught us a really important lesson that risk communications in a public health response is important, yes, but it's also, communication is also something that needs to be built into the entire public health management cycle, from preparedness to recovery to mitigation as well. And we need to strategically and innovatively think about how to build existing structures or how to strengthen existing structures to make sure that communications is built into the delivery of our primary health care, yes, at the community level, but also the delivery of health services generally. And I think that that's one of the things you're going to learn because you decided to spend your dinner with us. You're going to be hearing from experts from the Africa CDC, the Nigeria CDC. You're going to be hearing from a health journalist from Rwanda. I'm sure you have the program in front of you, so you know the people you're coming here to listen to. And I think it would just be really amazing if we can curate these lessons and take it forward, as we're all talking about, the new public health order and what we need to do to build capacities on the continent. And these are just examples of how that has happened. And I'm really looking forward to the discussions. Thank you so much. Sorry, I'm going to introduce the next speaker is Sunday Atovatele. He is Associate Principal at Sydani Group, and he will be taking you through the social listening project that revolutionized the rollout of the COVID-19 vaccination process in Nigeria. Please put your hands together for him.
All right, thank you very much. Okay. Thank you very much. Good evening, everyone. The past speakers have spoken to how you're spending your time here, excuse me, and how there are a number of other things you could be doing, but we'd also try to just maximize the time, shorten the presentations, and just have sufficient time for conversations. To talk about the social listening project, I think maybe just to talk about Sydani. Sydani is a management consulting firm, a young organization at that, incorporated in Nigeria in 2017. And between then and now, we've had projects across the country and some projects that were running outside of the country. This just shows the scope of our projects. And what we do is to just provide technical assistance to the government, to the private sector, in improving their processes, in solving problems. So we look at everything as to how can we make it better, what can be done differently. So even if there are things that are currently existing, it's more of what can we do to improve this. And some of the partners that we work with here, Gavi, the IVAC, CHAI, Results for Development, and a number of other partners. But the part we're focusing on for today, of course, building on the partnership with Nigeria Health Watch, is the social listening project funded by the US CDC. So during the wake of the pandemic, and then so there was the rapid development of the vaccines, and that came with a lot of questions. People raised different questions about the vaccines, the safety, how come within a year you have COVID-19 vaccine, but malaria has been on for a while and there is no vaccines for that. So there were a lot of questions as to were you really anticipating COVID-19? So, and with all of that, the social media was a very important tool for people to air their opinion. And Kevin Salah speaking earlier spoke about the social listening project that he did for vaccination in general. This is honing it down on COVID-19 vaccination. What are really the information out there that people are speaking about, and how do you not just extract information to respond to it, but how do you even use that to inform the thoughts? How do you use that to lead the thoughts about COVID-19 vaccination? Going from a reactive point to a proactive point. And at the beginning of this, we even had a meeting with the NCDC to even learn about the work they were doing, especially with the Tata food that just extracts information from social media and different platforms. So with all of that, we have the sorry for the breaking that. So we had the social listening project that was really bettered with funding from the USCDC and with direct support to the National Primary Healthcare Development Agency. That's the National Primary Healthcare Development Agency set up a COVID-19 Crisis Communication Center, CRIC. And as part of our support to the CRIC is to see how do we move from just putting out generic information to say the vaccine is safe, everybody go and take it. When people are saying different things, you're not addressing that, you're just putting out your own information, assuming that people don't have a mind of their own. So it's with this, the social listening was really looking at this from multiple perspectives. So there was I think Kemi already spoke to the social listening tool. So there was the social listening tool that sort of curates information from different social media platforms. As at the start of this, Twitter was banned, but later even when Twitter was, say, reactivated in Nigeria, so that became a primary or a leading source for information that we got from the social media. So it's tracking social media platforms to get information that you can use to drive vaccine confidence, increase the confidence in COVID-19, and ultimately even provide information about convenience, access to COVID-19 vaccination, sites where you can get the vaccines, what you need to do to get the vaccines, and all of that. So the objectives of the project were very simple. So we wanted to identify useful trends, insights, and all of that about vaccine confidence and hesitancy. And of course, identify information gaps and concerns regarding the uptake of vaccines. And then lastly, design a sustainable model for gathering that information for the government. Of course, this is strictly anchored within the CRIC of the MPHCDA. A sustainable model for gathering that information and using it to inform the communication that goes out, both at the national level and at the decentralized state level and even at the local government level. So I'll just invite Ms. Simi, who was the lead for the project, to speak to the methodology, some of the findings that we had, and the specifics of what we even did with the findings and some of the early outcomes of that finding and what we're looking at as the big picture for social listening, for communication, especially in pandemic setting. Thank you.
Thank you, Sunday. Good evening, everyone. So I'm going to be taking us through the social listening methodology. Working with the COVID-19 Crisis Communication Center, it was important that we had them carried along in every single thing that we did. So the first stage was for us to initiate, that is, determine what the search terms would be to input into the intelligence tool, which is supposed to sweep the social media platforms and get information about COVID-19 vaccination and vaccination processes. Right from initiate to disseminate, we have, a very good rapport with the COVID-19 Crisis Communication Center. I'm going to hone down into the analysis. So right here, after collecting the data from the social listening tool, we get two types of data. So we get quantitative data and we get qualitative data. And in analyzing those two, we decided on two different strategies for the analysis. First is using the SAGE 3C model, and the second is using a risk matrix for analysis. So the SAGE 3C model essentially is breaking the information you have into vaccine confidence, vaccine complacency, and vaccine convenience, right? It's supposed to help you determine what are people saying, and does that fall under vaccine confidence? What are people saying? Does that fall under vaccine convenience and complacency? And what we have here is just like the generic definitions of what confidence, convenience, and complacency actually means, and how we group them into positive and negative comments. And the next thing after that was to use the risk matrix to determine what will be reported immediately or not to the COVID-19 Crisis Communication Center. Like I earlier mentioned, that we work with them to create content and then disseminate these findings through social media platforms, right? So those are the two things that we did for the analysis. So I just wanted to show how, in terms of the numbers, how many social media platforms were actually swept through the 12 months of the projects. We had 310 social media platforms that were swept through the 12 months of the project. We had 76,000 social media handles that we did get information from, and we had over 6 million mentions talking about the COVID-19 vaccination and vaccination process, people talking about the convenience, people talking about the convenience, confidence, and complacency regarding COVID-19 vaccination, right? So now that you know how we carried out the social listening project, you know how we started and how we disseminated the project, I want to talk about what we actually did with the findings. So working with CREEK, we anchored our actions from the findings on 4 different things. First is sensitization, the second thing is content creation, the third is a mass vaccination campaign, and the fourth is capacity building. So for the sensitization bucket, we worked with CREEK to develop 49 FAQs that were going to change the narrative of people regarding COVID-19 vaccination, right? So people had questions that they needed generic answers to, so they can just go to the NPHCDA website, go on there, and then get their information. I just want to highlight quickly, for the mass vaccination campaign, it was actually a finding from Kwara State in Nigeria, where students in Kwara State University actually mentioned that they would have taken the COVID-19 vaccines if they had vaccination centers in closer proximity to Kwara State University. So what we did with this finding was to actually conduct a mass vaccination campaign in Kwara State for 5 days. And after that, we had over 1,700 people vaccinated in 5 days. And the third bucket is capacity building. We ensured that the state health education officers, who are the forefronters for social ACSM, which is advocacy, communication, and social mobilization in Nigeria, we ensured that they were trained on identifying what misinformation is, identifying what disinformation is, because it's important for them to know what these things are so that they can know how to develop content accordingly, right? And then the fourth thing, it was the content creation, which is like the most exciting part, where we find things and then we'd develop a graphic or an FAQ or anything that we have to put online, basically, to let them know like what we have found, and let them basically building trust between the government and the population, letting them know we found these things, we complained about it, we picked it up on social media, we let you know that we saw it, that you picked it up on social media, and then we're giving it back to you, essentially. Sorry. All right. So we outlined the impact of the social listening project, and we saw that over 7 million Nigerians were actually reached with the social listening project, from the social media content that was being disseminated, from the offline banners, from the radio jingles and things like that. All right, so here I'd spoken earlier to how we disaggregated our analysis into the stage 3C model and risk matrix. At the beginning of the project, at the beginning of the 12-month project, what we did was to conduct a baseline to understand where is the country at for vaccine confidence, where is the country at for convenience and complacency. And at the end of the 12 months, we actually saw that there was a 42% increase in vaccine confidence in Nigeria as of August 22, and there was a drop in complacency. So people no longer were tweeting or mentioning on Instagram that they didn't believe there was COVID-19, they didn't believe that the vaccine was effective or safe for uptake. And for vaccine convenience, which was increased by 35%, is actually really interesting to see because we kept on seeing things like they'd get to a particular center in a particular state and they wouldn't be able to take the COVID-19 vaccines. And working closely with the MPHCDA, we actually had like technical working groups, the logistics technical working group who would take up this finding and actually take the vaccines to the place. Like I earlier mentioned, like the Kwara MVC, how we had 1,700 plus people vaccinated in a space of 5 days just because of what we found on social media. Right, so in implementing the project, it was really important that we outlined like challenges that we had. In the introduction that we had from social listening, you'd already get that we had information swept from social media, which is online, the online population, right? So how did we mitigate this this difference? It was to work with partners like the NCDC, like getting reports from IRA, like attending infodemic management meetings. But then we still found that there was a gap. There was limited information, even with the data that we're trying to triangulate from partners. And we also saw that this made the reports not as robust as we had wanted it to be. And then for the funding bucket, I mentioned that we went to Kwara for the mass vaccination campaign, but that's just one state in everything that we had found. So if we had, funding for increased number of states, would have reached other states and would have been able to stay in Kwara for longer than 5 days, and maybe achieved a higher number than 1,700. All right, so the project social listening has come to an end now, and to ensure that all this hard work that has been done in 12 months doesn't just go down the drain and we go back to ground zero, we birthed a Listening for Impact project, right? So the project essentially would be a government-led system. We're going to work with partners and collaborate with them to ensure that the health system is in fact strengthened. The platform will improve the accuracy, completeness, and timeliness of ACSM data, that's advocacy, communication, and social mobilization data, reporting, analysis at all levels, from the community level to state level up onto national level, and it will facilitate supervision, improve evidence-based decision-making, and social listening in itself. Right. Thank you.
Thank you so much, Ms. Ime. It was really interesting listening to your presentation and what's been done. So very quickly, we will take 1 or 2 questions before we go into the panel session. Does anyone have a question? Going once. Oh, no questions. Great. Okay, so there's a question. Oh, that's okay. So just those 2, please. Can we get a mic to him and him? And you please just go straight, ask your question, then we'll move to the next session.
Yeah, hi, thank you very much. Very interesting discussion. Just wondering if there's any thought, in the same way that ByteDance, the owners of TikTok and Facebook and other social media companies, use cookies to collect really deep insights about their users, is there any thought about encouraging, national public health institutes and government agencies to ask permission for people, but use cookies and really go deep into people's histories to understand them better than they know themselves? Thank you.
Great question. Let's take the second one, and then we'll then just quickly answer him. The person in the cap in front, over there. Can you just raise your hand so she knows it's you? Thanks.
All right, thank you so much. That was a great presentation. I have some questions. I think the first is, considering the success made with this, is there a consideration to use the same model to actually inform or promote communication for some other programs, like immunization and family planning, as we would require in most part of the northern states in Nigeria? That's one. You mentioned a lot of trust in the government. Is there something you think the government needs to do to actually improve, the trust the people has in it? And then thirdly is beyond social media, I know there is also the use of the traditional, platform. Is there a consideration into what needs to be done to ensure that people in the rural areas or the older people that don't have access to social media can actually access this type of information to actually change their perception around some health programs and service uptake?
Great, thanks. Are your questions directed at Sunday or me? Because a lot of your questions I already spoke to during our presentation. So,
so maybe more
assuming Sunday, yeah.
Yes.
Okay, great. Sunday? Yes, really quickly. I'm going to give you just 2 minutes, like literally 2 minutes.
All right, thank you. Let me start with the last question. So about what we can do, of course, with the northern part of Nigeria, the plan is we started with COVID-19 vaccination, but the plan is to expand to immunization. Again, we also understand that there are platforms that are doing some of this work. So it's not to start another one and just go in parallel. It's to have collaborations with existing platforms and integrate whatever we're doing with what exists to collate the information and then decentralize it for use across the states. We're also working with the different states to set up some communication system, some system for them to extract this information and use it for their own states. So national is not sending everything down. So beyond even the northern states, this is going to be done across all the states for targeted communication for them to use for immunization, even beyond COVID-19 vaccination. For the question about using cookies, that's something we'll take back and then see how to move forward with it. But yeah, thank you very much for that great idea.
Thank you. So without further ado, please put your hands together as I make welcome the Managing Director of Nigeria Health Watch, Vivian Ihekwezu, as she moderates the next panel session. She will be introducing the speakers to you. But if you want to know more about them, their bios are right there in the program. Vivian?
Thank you very much, Kemi. I'll just invite the panelists to come and get seated. And as Kemi mentioned, the detailed bios are in the program that we've shared. And I think it would be good if you look through them so you have a better idea about the panelists. I think sometimes we rush through this a bit, and I think being able to read that yourself would also enable you to get to know them a bit better. So our first panelist I'd like to invite is Dr. Benjamin Dubarrier, who is the Head of Policy, Head Diplomacy and Communications at the Africa Center for Disease Control. Dr. Benjamin, welcome to this. Oh, just sit anywhere. Next, I'd like to invite Agre Aluso, who's the Director, Africa Region from Pandemic Action Network. Next, I'd like to invite Dr. Yahya Disu, who is the Head of Risk Communications at NCDC, Nigeria Center for Disease Control. And last but not least, Aimable Touahira, come to the podium. Stage, sorry. He's a science journalist from Kigali, Rwanda. He's a freelance journalist, freelance science journalist. So you're all welcome. I think we've had some important lessons shared about some of the work we've done at Nigeria Health Watch, and also the work done by Sydani in terms of social listening and otherwise. But this panel session really is to kind of tease out in greater detail how different organizations also used health communications and how that informed the public health response, learning from now and also going forward in the future. So my first question I would like to address to Dr. Benjamin. As I said, he's the head of policy and diplomacy and communication at Africa CDC. So of course, a very, very important body. Sorry, can we share some more mics with everybody? Yeah. Okay, so my first question to you, Dr. Banjima, is the Africa Union, through the Africa CDC, provides regional insight and coordination for public health emergency and response. From your perspective, how important and integral would you say health communications is in emergency public health responses?
Thank you very much, Vivian, and thank you for inviting Africa CDC to be part of this very important discussion. Needless to underscore really the importance of public health communication here, but for us to answer to your question and to go quickly, I will itemize my responses. And number one is to have a clear and effective line of communication between political leadership and experts. That is extremely important to support public health measures during any public health crisis. The second is to have an open and efficient communication channel outlining the response strategy step by step. That is extremely important. And the third is a practical and clear line of communication between experts and the public, especially to guide social behavior change. So these are the three main steps or actions when we need to communicate efficiently during public health crisis.
Okay. Thank you very much for that, Dr. Banjima. I think those 3 points are very important, especially how you mentioned having a clear line of sight in terms of communication. I think Africa CDC really was a key body in terms of informing how countries were able to guide their responses. So going from kind of the Africa-wide to specific country, Dr. Disu, sorry. Apologies for this. Sorry about this, guys. Apologies for that. Sorry. Sorry, Dr. Disu. Next question is for you. You are the head of risk communications at NCDC, and I think during her presentation, Kemi mentioned the Take Responsibility campaign. So can you please talk us through the design and implementation of this campaign? Because it was an effective way that that communications was used, as Dr. Banja mentioned, to get a clear line of sight in communicating to Nigerians how they can respond or how they can take preventative measures to protect themselves and their communities against COVID-19.
Thank you very much. And I think Nigerian Center for Disease Control and Prevention is grateful to Nigeria Health Watch for giving us this platform to share our experience. And again, you've been collaborating with us with other partners like Sydani and other partners that in this room. And we Take Responsibility campaign. I think we all understood the beginning of COVID-19, which was characterized by widespread panic and anxiety. Against that backdrop, we started developing messages and to just inform the people of what actions they needed to take. But with time, we realized that there were challenges, what I call VUCA, due to volatility of the problem, the complexity, the uncertainty and ambiguity. And then we knew that in order for us to succeed, we needed trust of the people for the overall success of the response. We also needed the respect. We needed to respect the values and the beliefs of the people in order for us to adapt our intervention to make it acceptable to them, as well as we needed to understand their needs and concerns so that our interventions can be effective and efficient. Then the other thing was that we realized that we needed a strategy that would kind of maintain trust and then empower the people to make informed decisions and give them reliable alternatives. So, and we looked at all this, and then we realized that we needed to work as a team with every stakeholder, particularly the community societies. That was when we adopted the whole of society approach. So we're now looking for a theme that will encapsulate this. And then the team brainstormed, that's the communication team. I will talk about them later. And then until we came up with a theme that we felt would resonate with everybody, that will distill the essence of our campaign. That will take responsibility. That will empower people at individual level at the community level, family level, and even policy making level. That's how we came about the Take Responsibility campaign. How did we implement this? We also realized that we needed to make sure that all stakeholders are on the same page through our robust communication pillar, this communication technical working group at the EOC. We have it at various levels, and we ensure that there is synergy. Even at the leadership of the NCDC, we have a crisis communication platform that the DG himself was leading then, and then also the heads of departments, the pillar leads, then as well as the other partners like Nigerian Health Watch and other partners who are represented in that, so that we can make decisions quickly. So, and after that, what we now did was we also ensured that data, we needed to be getting data for us to understand needs and concerns of the people, and then again to be able to adapt our responses. So that way we're triangulating data across the social media platform. And then the NOI poll, the weekly polls we were doing, and then we're also tracking the trust index, how people are trusting the government, their fears, their knowledge perception. So at the end of the day, we were able to get information that will help us to inform the EOC itself in terms of the strategies, our messaging, as well as to know what quality information we need to give to the general public. So putting all this together, we're able to ensure that the Take Responsibility campaign lasted on for a long time. But we also ensure the channels, we engage the media. Media, they were stakeholders, because at that point in time when there was lockdown, they were the means that we can quickly use to disseminate information to the people, and because people trusted them. We also use these channels, that is social media platforms, to be disseminating information. After a while, the Twitter was banned in Nigeria. It became a huge challenge for us. And then also the traditional leaders, religious leaders, were also engaged at various fora, both at highest level and at the community level. You remember we adopted all of society approach. And then as time went by, we continued to evolve the communication strategy for us to be able to get to where we have today. Thank you.
Thank you for that, Dr. Dusu. I think, some of the things I take out was, the Take Responsibility campaign was driven, of course, the anchor was the NCDC that drove it, but it was a whole of society response. So involving the community, involving the media. And this multi-sectoral approach ensured that everybody was involved in the communications campaign. So it wasn't just left to one single institution, but you brought in different, civil society, the media, private sector, etc. My next question to you is, Agri. You are Director of Africa Region for Pandemic Action Network, and this was born out of, the COVID-19 response. How do you form a coalition of civil society partners in not just talking about COVID-19 specifically, but also talking about epidemic responses and talking about how do we, as a coalition, advocate collectively for policies going forwards that are to the benefit of individual countries, and how do we negotiate collectively as civil society to ensure that we are also we're also sitting at that table where policies are developed for pandemic preparedness going forwards. So it's grown significantly over the last few years. Can you share from your experience on how you went about building a strong network and setting up a technical working group, and how did this evolve, especially in building a health communications pillar through Pandemic Action Network?
Thank you. So thank you very much for having me here, and good evening, ladies and gentlemen. Just a disclaimer, and note that I'm not going to answer that question. I'm just about a month old in this role, and it's a very wonderful space, and I have quite I've internalized a bit of the historical perspective of what has really evolved and shaped the agenda of Pandemic Action Network, from when it was conceived and up to this point. So I think for those of us who have interacted with Pandemic Action Network, it was a reactionary organization. The coming into being was in response to the pandemic that hit the world unexpectedly, and we had to really gather ourselves and just have a clear understanding of where things are heading. Are they heading in the right direction? and who is being left behind, and how do we ensure that nobody's left behind in this process. So I think that process, it had to be a very, it was organic, but also, a catalytic process that involved some visionary colleagues who have been involved in this work in different spaces, coming together to, initiate and get this moving. And I think it really involved a lot of, onboarding and agenda setting with various, segments of stakeholders, and it's across broad-based membership, which has civil society organizations, it has, private sector, it has intergovernmental agencies, academic, and so on and so forth. And I think the work that has gone into really creating this vibrant advocacy space, is really building on to very, good tradition of effective communication. So one of the co-founders, Eloy Todd, was working with One, and you know how vibrant One is in terms of communication. So I think, and another colleague was working with, had just come from Path, and Path is also very invested. And another one was already, involved. And, different colleagues with, background, very deep, rich background in public health communication came together to really create these vibrant organizations. And it has grown over time. And I think in Africa, we have done quite well, in really socializing this idea that we need to come together, collectivize, and have this critical mass of people who, are convinced that things need to go in a particular direction, and, defining that agenda and tapping onto the expertise that exists. For example, the Nigeria Health Watch. So really within the collective of societies that, identified with what PAN, stood for, we are able to identify now who brings what on the table. And we are able to let colleagues and we are able to let partners run with different ideas and, measure on the areas of strength that they possess. So for example, one example, the Africa Mask Week, and I'm sure Nigeria Health Watch can talk more about that. We're able to work with specific groups of organizations, including the ones like Nigeria Health Watch, which is already invested in public health communication, and other, targeted demographic groups like the youth organizations, to be able to develop messages and run with them in the specific areas of, of operations, like geographically, and also with the specific categories of population that you're already working with. And I think that's how we are envisaging, growing the PAN network. It's not about one person being at the center and, pretending to know it all. It's about bringing the collective and identifying who has what strength, and creating an enabling environment for that person or that organization to move forward and help the general good, or to help support the vision, the shared vision of the membership.
Thank you very much for that, I agree. I think one of the key themes in what you're saying is the strength of collaboration and how CSOs come together. Everybody has their individual area of expertise. Every organization has their individual strength. And in a way, by collectively putting all those together, advocacy is made a lot easier because, one cannot go it alone. Collectively, civil society organizations, and this, I think, is a key learning as we advocate collectively going forwards. How do we have one voice so that when we push an agenda, or when we want to make sure our agenda is heard, we're doing it as a collective, not as an individual. So thank you very much for that. It's a very, very poignant point about the power of collaboration. Thank you for that. My next question is to Imable. You occupy a very important role. We talked about the multiple platforms that we use for communications. We talked a lot about social media, which is a very important tool, as we all know. But the media really, as we say, is a fourth realm of the state. And the media is almost the voice that informs the public about different interventions. And you, as a freelance IS journalist, are at the forefront of this. So my question to you is, how did you use evidence-based information and communications in Rwanda to effectively communicate to the public? How do they how to take preventive measures in response to the COVID-19 pandemic, and what lessons have you learned, or have journalists learned going forwards with this?
Thank you again for having me. The key to this was to put the problem solving at the center of the narrative. So as a science journalist, the responsibility of science journalists is just to consult. You are not the one to make news. You have to consult scientific community and then conveying that information to the non-specialized audience. So key to this was I like to interpret those scientific reliable evidence over other information. So how do you use those evidence? You need to use data, being either qualitative and quantitative. So there are like scientific studies that need to be assessed. Of course, during the pandemic, when the WHO declared the outbreak of COVID-19 as a pandemic, so there were some scientific studies that needed to be assessed for quality and relevance. So as a reporter, you need to be trained enough to understand those facts. If you are really the lack of evidence on some of those publications and has led just to some public mistrust. For example, if we need to talk like to vaccination acceptance, some people were reluctant just to accept because they are mistrust, public mistrust, because there is lack of evidence. So the thing was that cause of lockdown, though, also there was another issue of interviewing researchers, because most of researchers sometimes say it will be really challenging to talk to reporter when he's not specialized enough to understand, to interpret, to convey that information to the average person. So that has been some of the challenge. So to overcome those challenges was like using a number of tools, just there are a number of tools now available online that you can just use to access to some accurate relevant data that can just be used to cross-check, but cross-check fact if those really are coming from authoritative sources. That has been one of the things. And apart from that, we have been engaging researcher in one way, because during lockdown, even those people, our main sources, which include researcher, of course, we are busy engaging in other intervention in healthcare area. Then the way it was really being challenged, but using those tools like Zoom, like other tools, we are engaging them so they can come up with the reporter, science reporter, to train them, to educate them, to inform them how they can interpret those data. So this science evidence have also led to some extent to vaccine acceptance, because when you try to show, because I can give you an example of Rwanda Biomedical Center. We have been distributing daily some dashboard with like new cases, this could help people to most of media, you realize that we're most focusing on reporting on those figures, but it was important to, because the role of journalists to ask questions. If you have to ask questions, what kind of question I have to put to researcher? So it's important to understand those figures, to interpret those data. So data journalism is key to all of this, to able to interpret, and then so that you are able to ask questions, because you are not the one making news. So another thing was there is a lot of information. You need to rely, of course, on scientific experts. You don't need just like being academia, even from other authoritative sources, like as I said, like Rwanda Biomedical Center, which is a lead organization in the health sector. So I think that has also been to some extent very important, because the way they were disseminating, helping people to understand, as soon as they share those information, it was really challenge. It was no longer a challenge for them to convey the accurate information to the average person.
Okay, thank you very much for that. And I think you mentioned the use of evidence-based information and how you worked with the Rwanda Biomedical Center in training journalists. Very important. I think in Nigeria Health, which is something we also do and did, in terms of training journalists. I'd like to ask you, actually, Dr. Dusu, a similar question. How did NCDC work with journalists in the way Aimable mentioned, that the science journalists work with the the National Public Health Institute in Rwanda to train journalists. How did you also work with journalists to ensure that what was communicated was evidence-based and you are conveying the right information?
Okay. First thing to understand the journalists themselves, their needs, their concern. You remember in 2014 during Ebola outbreak in Nigeria, how journalists themselves were sometimes they reported what was not accurate. There was even a time they mentioned the name of somebody, I think was a contact, and but we realized then that engagement of journalists is very critical for the success of the outbreak. They can make or mar the outbreak. So in Nigeria, for this COVID-19, one of the things we did was we trained the journalists. We worked with our partners who have experience in this, Nigerian Health Watch, even Breakthrough Action Nigeria. The first training we even organized then was supported by Breakthrough Action Nigeria then for this COVID-19 response. And then, so after we trained them on how to translate technical information into understandable narratives, and then again on infodemic management, how to verify information, how not to further fuel misinformation. So this training, before the end of 2020 or 2021, we're able to train over 500 journalists in the country. That is in conjunction with our partners. Then we also have a platform where we share information, a WhatsApp platform where all the media outfits in the country, they have representatives, they ask questions, and we continue to ensure that we respond to their needs timely. And then more innovative thing the organization also did was to deploy a microsite for COVID-19 response. And then that way, a lot of journalists find this as a very useful resource. And they go there, if they have anything they don't understand, they call us, and then we respond to them. And then with frequent press releases, and then we're able to update them and then address their fears and concerns. And then even at the leadership level, I remember that time, every day, the Presidential Task Force, they were organizing press release, press briefings every day to clear the doubts and then answer questions from journalists. So training is an ongoing thing. And then one of the key lessons we have learned from that, right now, we are starting a training curriculum for journalists, in-depth course for them. We call it Media EIS. We're working with Affinet and Breakthrough Action to do that. What that means is for E stands for epidemiology. That's the science of public health. For them to be able to understand what they are reporting and when they want to interview people, and so that they don't even misquote or misreport scientists. And then two, for infodemic management, they should be able to report accurately. They should be able to verify information before they report. They should be able to distinguish what is disinformation from accurate information. And the social and behavioral change component, which Breakthrough Action is supporting, is how can they report in a way that will translate to behavior change. It's not just give people messages. So that's one thing we're doing now, and then we've already done needs assessment in the country, and then we have already set up a stakeholder forum with the BOM, Broadcast Organization of Nigeria, and other stakeholders, as to make sure that they are part of this training. One other critical thing we are also doing for the media is to ensure that we continue to respond to their queries. Each time they send queries, we respond, and then when they invite us for media appearances, we do that. And then we have trained spokespersons in NCDC, and then right now we have about 40 trained spokespersons, and that was very helpful for us in 2020, before pandemic. We trained them around between, I think, whether July and August to September. It's a 3-month training, 20 spokespersons. We didn't know the pandemic was coming in 2020. So when we were getting requests, so it was easy to just deploy our trained spokespersons to attend to needs of this media, whether it's radio, electronic, and so on and so forth. So preparedness is very key, as in taking the media very seriously. It's very important. You can imagine if it's only DG that can be the one that can be talking to the media, he will be overwhelmed. It's also tasked with other activities that are very critical for the response. So I think that is a continuous thing, and then to ensure that we engage media as stakeholders. In our Nigerian infodemic management team that we have formed now, media representatives are also there. We look at data together, just like Sydani mentioned earlier, And then they also attend that meeting every Monday, and then we look at the data for the past 1 week, analyze the content, and then we also get perspective from the media, and that really helped us. When we even develop our strategy, infodemic management strategy, they are there. They have also been co-opted into a National Risk Communication Technical Working Group. So we're not just talking about engaging the media or just give them information. They are part of us. We walk through this together. We are all in this together. Thank you.
Okay, thank you for that, Dr. Disu. And I think you've mentioned some very, very important points, especially the aspect of actually working with the media. So you're getting information from them, and also they're getting information from you. And also building the capacity of people within the Public Health Institute to be able to report and to be able to discuss the outbreak. It's something we often take for granted, that communications are that easy. But, you know, informing and sharing and doing training with them and ensuring that people within NCDC, in your case, actually have the capacity to actually speak about outbreak response to people and be able to communicate it in clear, simple language. I think sometimes, you know, as scientists, it's very easy to get bogged down in, you know, the large technical terms. So having that capacity to speak to ordinary Nigerians or ordinary Rwandese in those simple terms, I think is critical, because if people don't understand what you're saying, they're not going to know how to respond. In a similar way, Dr. Benjamin, for Africa CDC, how did you, because I know you had quite a lot of press briefings throughout, how did you work with the media in terms of sharing information about the outbreak, but also building the capacity to report on not just COVID-19, but, you know, lessons learned going forwards? How do you think the work you've done has strengthened the capacity of the journalists to report on news, and also your ability to work with the media to share the work that you're doing at Africa CDC?
Thank you very much. What we did was not very different from what Dr. Disu just mentioned. It was the same strategy, and at some point we even crossed paths, you know, in terms of training people. So, you know, we, at the very early days of the COVID-19, just toward the end of February 2020, when we had our COVID-19 strategy in place, COVID response strategy in place, well, from that one, we had our communication strategy, risk communication and community engagement strategy, and we started building capacity across the continent. But we did not limit ourselves just to, you know, to journalists, but also we bring in all the focal persons on risk communication, community engagement across the member state. At that time, I think we brought 40 countries in Tunisia, and they received the first training, and then they went back home to cascade it down at that level. That was the first thing we did. We have the regular briefing with the journalists. When the director is addressing the journalists, briefing them regularly, and also bringing briefing in-house, because sometimes, you know, we are taking it from granted, but you need to bring the people in-house at the same level of information. It is critically important. The other thing that we did in that regard was to train also the network of journalists across the continent. And we are going to form very soon, I think early next year, a community of practice of journalists, because we have already one community of practice for risk communication and community engagement experts in place, and we are going to replicate that model for journalists across the continent, because they are our allies. Yes. And it is extremely important that they report accurately the information rather than misquoting people. And we have learned that lesson from the Ebola outbreak. And thank you, Disu, for bringing it out here. So thank you.
Thank you very much for that, Dr. Benjamin. I think your mention of community of practice is critical, because that's how you're able to pool knowledge collectively and using that as a model going forwards to strengthen capacity of journalists in reporting not just on Ebola, COVID-19, but other outbreaks that are happening and continue and would happen, as we all know. My next question is to Agri, but before I ask Agri the question, please we probably have time for maybe one or two questions. So if you have a question, just keep it in mind so that once I ask the final question now, then we can open it up so that if anybody has any questions, they can now ask. My question to you is, there's one aspect that we haven't, spoken about yet, and we alluded to it earlier when we did some of the presentations, which is vaccine delivery. We know how misinformation, disinformation impacted uptake of vaccines. So, what are some of the lessons you can share from the work you've done around reducing vaccine hesitancy using risk communications?
Yeah, so thank you. And that's work that I've done in various other spaces before my current role. And I think it was one of the most difficult things, not because people did not want vaccines, but because the politics around how vaccine eventually became available. The whole panic mode, and I think somebody spoke about it, when we were told, this is going to be an apocalypse of sorts for Africa, and there were all this depiction of how tragic it was going to be. People were genuinely scared. And also when now developments were evolving and we saw prospects of vaccines become available, we were excited. And then all of a sudden, it was for other people and not us. So we had those dual challenges. So there was that structural challenge of inequity and the politics of who had money to buy, and everybody who had money bought stockpile like 5 times what their countries needed, and we know those countries. We're not going to mention them here. And Africa was left, behind there, struggling and waiting for this uncertainty. So when vaccines became available, I think there was a very deep-seated mistrust about this whole thing that initially was not. It was available for other people, but not us. And now we are being told we need to have it. So that has been a very difficult tide to change, because people died. A lot of people died because they didn't access vaccine on time. My father died because he didn't access vaccine on time. Many older people with underlying conditions died. And many other people survived because of other advantages they had, maybe age or maybe, just biological advantages. And that just showed like, we don't actually need it. So it became a very difficult scenario to convince people in a context where this development and this commodity was shrouded in a lot of iniquities and deep-seated injustices that now it's available and people don't want it. So that's a very difficult one. But also, I think different dynamics evolved, and there's a clip, if we get time, we'll play. Different dynamics evolved, depending on who was where and your level of health literacy. So we saw the dynamics of rural versus urban, educated versus uneducated, and really the germ theory has always been a challenging thing. And they are symptomatic people, particularly the younger populations, who would be told you could be having COVID, yet you don't see the signs. And really, there was a lot of misinformation. And what really aggravated this scenario in Africa was how the information was handed down. We saw a lot of authoritarianism, top-down, decrease, and that just created a whole system of mistrust of anything government was doing. And the corruption and lack of accountability just made people think this is something they want to make money from. So it confounded the whole dynamics around acceptance of these remedies that were now being availed. But I think the clear ones that most civil society organizations, were attempting to address were the myths that evolved over time. And somebody talked about religious groups. If you are in East Africa, you would have heard about Catholic scientists. I'm sure Africa CDC know about it. The Catholic scientists who were the first one to pronounce themselves against the COVID vaccine. And it took a lot of time. The ironical thing about it, the person who went before the media to say how this thing, we don't need vaccine, people can fight it. He died of COVID in Kenya, unfortunately. And we didn't know how to react, like, oh, that's unfortunate. Yeah, but many people also died because of what he said. So I think we really struggled. And one thing that I did when I was still working at the Open Society Foundation was really to try and get different groups that were very vulnerable and did not have the right information. So all the things we've talked about, the beautiful things we talk about here, are really for people who have access to the modern media outlets. This is a bulk of population in the rural areas who rely on word of mouth, like the ones who took salty water, in Nigeria. But, in most rural Africa, we have people who do not have these formal channels, and they rely on this physical word of mouth and have been struggling. And unfortunately, the older people in the rural areas who have taken this, and I always struggle, and I'm sure all of you struggle, when you hear this person who you really think needs to have the first jab, and they say, no, this will make this, and you end up confounding their life. So we tried to really contextualize, and what really confounds or really makes this communication difficult is because the information is not contextualized for them to understand. And we are making a lot of assumptions. People used to communicate risk issues. My grandmother told me how when smallpox would hit a village, people would suspend all the cultural practices and move and leave those who are very weak, and make that sacrifice for the benefit of those who survive. And then this evolved later, and then we have other complications. So really contextualizing this information and having it in ways that people understand, getting people that they trust to deliver it, and making sure the right information is delivered by the trusted people. So really the public health approach using community health workers, people who are in the community, who they trust, who they see every day, not this stranger who is speaking through other foreign languages speaking to them. Yeah.
Okay, and thank you very much for that. I'm really sorry to hear about your father. I think we can all share similar stories of people who didn't access vaccines and unfortunately passed away due to lack of access, also due to misinformation, as you mentioned. The Catholic scientists are very, very poignant, and I think most people can identify with hearing stories about how misinformation was spread. How very rightfully you mentioned that a lot of what we've discussed today, social media, even press, does not reach communities. And I'm sure you listened to Kemi's presentation when she talked about the way we're working now in communities to collect misinformation and use those community structures to debunk misinformation. Because we all know that people often accept information when they are speaking to people they can relate with, who are often in their communities and they see as trusted sources. My final question to you is, Imable, you, as I mentioned, you're a science journalist, and we've talked a lot, as Agri mentioned, about the role of distrust. So it'd be interesting to hear from you how in the work you did, how can you share lessons learned on how in Rwanda you went about building that trust using the media in things like the vaccines or even the initial COVID response?
Thank you so much. So first of all, I will say that there was a challenge of face-to-face interview, because most of the time when it comes to report on research, scientific finding, journalists need to ask many questions. There is somehow you need to ask as many questions. So face-to-face interview was really a restriction for many. So newsroom also were running out of resources, and some of them were not able to keep working as usual. So when it comes to this interaction between researcher and the journalist, so it has been really challenging, because even many researchers were even not well trained, we are not ready to use those available to just communicate, like those online tools like Zoom. So it was really a challenge for both parties, both from journalists, from source to interact, because even no one was able to use was ready to use those available to just communicate, to interact, so that journalists can ask as many questions to get the information across. So another thing is about fact checking. Fact checking also was another challenge for journalists, because there have been this misinformation and disinformation, because there are many people spreading rumors online. So it was really not really, some of science reporters were not to able to separate, differentiate from those accurate information. So what was needed was to train them on how to use a number of tools available online, just to cross-check, like how to check if a website is really accurate, the source of your information, if it's a report, where did you get this information from? That's something that helped to overcome all this challenge. So another thing is about the global, as I mentioned in my previous area, is this Global Health Crisis Reporting Forum of the International Center of Journalists. We have been engaging a number of journalists, train them, and I have the deputy of that program actually, and we are training them on how to use all those kind of tools to fact checking. Apart from fact checking, we also training them, engaging them, inviting a researcher, exchanging them, so that they can be able to get a message across, a scientific information across. Another thing, another challenge was how the researcher communicate their finding. We also try to engage researcher just to simplify their message, because most of the time it's a scientific jargon, which is really hard for journalists to pick and then get message across to the non-specialized audience. So it was also another way of engaging in that way. So after all of those, we need to get equipped with skill from both parts. So that's how we just we managed to overcome all those challenges.
Okay, thank you. Thank you very much. And I think I like what you said about, I think I said it before, about the use of jargon and how you're able to break that down into simple language so that it's easy to understand. We have time for maybe one or two questions, and we'll wrap up thereafter. We've got one gentleman at the back who has a question to ask. Just state your question briefly and who it's directed at. Thank you very much.
Thank you. My name is Robert. I come from CDC Rwanda. Quickly, I want to first thank you. This was a very, very important aspect in this whole conference, to add communication. Starting from what you just ended with, the jargon, I really want to understand how you break down and bring in a human interest story from technical work. Most of us are doing technical work. Our scientists on the field, they are busy responding to an emergency. How do we bring in the human interest in order to capture that public interest? And maybe that is to Africa CDC. And maybe to Sydani, briefly, you mentioned something about, and I'm seated with CEO, but you mentioned about something about covering, everyone was involved. How did you get the buy-in to have everyone involved? Did you use government? Who was your major partner? Did you use police? Did you use, some countries had to use police in order to, to deliver and have that behavior change. But how did you get everyone involved? Thank you.
So that question is directed at anyone on the panel or Sydani specifically?
Anyone.
Anyone, okay. So next question.
Good evening, the panelists. Thank you for this insightful and really rich discussion. I have two questions, or one question and then one appeal. I appreciate the concept that was mentioned by the Africa CDC of developing community of practice. I think I will appeal to NCDC to also look into that model, because there's a need to maintain a robust network that will help in managing distrust, and because communities are used to ACSM, and then so people come with the concept of RCCE. So there was that confusion, literacy level for in Nigeria. So that the interswitch between ACCM and RCCE And but if you have kind of a committee of practice and network, because people tend to trust information from identifying who is giving the information. Yeah, so I see Dr. Disu. This is the first time I'm seeing you. I only see you in TV, but if today, if today I live with people and I said this is what I so because I belong to this group, so it will encourage acceptance. And thank you so much.
Would you say he looks better in person compared to on TV? Okay. Thank you for that. Thank you very much for that question. But also, I'll challenge you: RCC, ACCM. Does everybody understand what those even mean? So I think sometimes we also get bogged down in our own acronyms in public health, so we kind of exclude people from understanding, or you're waiting for someone to go and quickly Google what is he talking about, because you don't want to sound like you're uninformed. But thank you for that comment stroke question, and you heard what he said. Now he's seeing you in person, Dr. Disu. I'm sure he's quite happy. So who wants to take that question about jargon? It's a very important one. Yes, thank you. Yes.
No, thank you very much for the question on the jargons. For us, maybe because we have different type of audiences, it is easy for us to communicate in a very simple way. Because when we conducted the research, we will use the scientific and technical language for the technical people, but that is for the experts. We have other policy organs at the African Union. So we have the ambassadors. Now, the way we communicate the same message to them, we change the language, right? We can communicate to them through a policy brief, but using a very simple language that everybody can understand. And it goes up to the level of the head of state and government. So for us, it is very easy to do so. And Lillian is sitting here. We were making a communication out, releasing a scientific communication 2 days ago, and it was full of scientific jargons, words, but we bring it to a very simple language. So that one is something that it is not easy, at the onset, but when you get used to it, it will be, you can simplify the language. So, yeah.
Thank you very much. I hope that answers your question. I actually forgot to mention initially that we actually have an online audience also listening into this session, this side event. So thank you very much to our online audience. We know we've got quite a few people online. And we actually received one online question, although I said we'd just take two. Just crave your indulgence. We have one online question. I'd like to direct it to you, Imab. It's actually quite an important one in terms of media. And the question is, normally after building the capacity of reporters in terms of reportage during outbreaks, they always tend to still adopt the sensational news approach. What do you think we can do to regulate sensational reporting, which might be harmful to the public? Do we also engage their regulatory bodies to institutionalize compliance to protocols set during this training? So, over to you.
Okay, thank you so much. So as I said, most of our story, we need to put the problem solving at the center of our narrative. So that's the key for each and the message we need to get across. So for solution, actually when we are scientists or we are science journalists, whatever message, you have to learn impact story. What kind of message you need to get across, what the impact you have on the community at a policy level. To some extent, you need to assess. And that's one of the reasons I'm saying it's very important just to put most of our story in the context. Of course, we need to give like a perspective and provide potential solution. Just instead of just using number and you don't even understand what you are telling. You need to understand how to tell the story out of number. How to use number to test, using the number to test story. Because most of the case, as we are talking evidence-based, it's much more about qualitative and quantitative data. If you are not able to interpret all this, how you are going to get the message across, how you are putting the problem solving out of this narrative. That's the key for this one. Thank you so much.
Okay, thank you. Thank you, Matt. Unless anybody wants to add to what Imab said, because it's actually quite an important topic, because you know, I think sometimes even us as an organization, Nigeria Health Watch, we host events and we engage the media. And sometimes the way it gets reported tends to be something completely different. And that speaks to the importance of communication and clear communication. And I think that's why, you know, Imabli mentioned also Dr. Disu, how you work with, you know, journalists in training also at Africa CDC, how that partnership ensures that you're building their capacity to report accurately as much as possible. And when it's scientific and quite technical, that training is also very helpful in everything that we do, because, you know, communication basically speaks to how do you speak to somebody in a language that they are able to understand. And also, not just they understand, they now convey that same information to everybody else. I think we've all heard about Chinese whispers. You mention a story to one person and then 30 people later, what's that 30th person actually saying? And that speaks to the way each person communicates along that chain. So thank you very much for that. I think, Agre, you want to add to that?
I just wanted to add to that. And I had a tragic experience with sensational journalism in my previous life. So I used to, I was doing public health work, you know, scaling up HIV response for key populations. I'm sure most of you know key populations. So, you know, it's in very contextualized, you know, space. And we call journalists, you know, to just get them understand this concept, that it's for everybody's benefit that we target, we do differentiated HIV response for different groups, because, you know, we've seen the drivers of the pandemic at that time. And we were in our hotel in Mombasa, and we had ground rules, and we agreed this is just sharing, we will synthesize, and we will agree on how to support it to report. And then at that time, we had just done size estimates for different key populations. So there was this preliminary report. So we said, like, oh, this is how it looks like. You know, these are the number of men having sex with men. This is the number of sex workers, the number of drug users. And one journalist just took a screenshot of what was being presented. And by the time I left that place, my boss was calling me, like, what have you done? It was trending. All over East Africa, you know, how many gay men are in Mombasa or Kisumu. And I was like, okay. So everybody was calling me at this time. So I think this is a very important point. So what we really agree, so it informed the work that I've done with the media for a long time now. Since that time, that was about 7 years, 8 years ago. And I just realized that we need to have this from, you know, from the source. So I started engaging with the Media Council, you know, bodies of the region, and just agreeing with them that the purpose, you really need to know the purpose of this engagement. It's not about the sensational element of, you know, getting people excited and getting hits. And this was a journalist who wanted to be known. And, you know, just to, you know, like, you know, you're trending, who reported this? And so I think we have had a good run and working with the regulatory bodies and just having a clear understanding the protocols of reporting. And it became an issue. If you do those kind of reporting that impacts on people's lives, then there's a sanction that the regulatory body of media would do. And I think that's something that can be regulated. And, you know, you don't just take people's lived reality and make a story out of it for the sake of getting hit. Yeah.
Yeah. Thank you very much for that. Did you want to add to that, Dr. Disu? Okay, do you want to take that question?
With regards to how to engage everybody, I just want to share our experience, what we have done in NCDC. Of course, it seems utopian to say you want to engage everybody, but the important thing is identify the critical stakeholders. The situation determines who you engage. You need to do your needs assessment and then do your stakeholders mapping. At the same time, you need to analyze your stakeholders based on interest and influence, and then you'll be able to. For instance, we've been doing stakeholder engagement at the NCDC until COVID-19 pandemic, when everybody becomes a stakeholder, as in even the oil companies, everybody. Then our DG then, Dr. Chikwe, he will just send them to you, this will engage with your team. Like, what do we do? At the point we have to be innovative, because we have to develop a four-pronged approach for stakeholder engagement. So we use sector approach. Education sector, Ministry of Education is leading. So all the stakeholders in the education sector, they are meeting. I think Nigeria Health Watch was also involved in some of those meetings. For sports, we did the same thing. For INEC and also the NYSC and so on and so forth. So that was what we did. So the four-pronged approach includes, one, and develop a sector-wide guideline. We supported them to develop a guideline. For a safe school reopening, we did that. Then the second one is provide technical support for the implementation of the guideline. You don't develop the guideline and assume that they know how to implement it. They will have challenges. So we're supporting them until the first one we developed for education was very complex. They said it was a Bible. We went to the Ministry of Education. They said nobody will understand it. We have to break it down into the 4-point again, and that we talk about the protocols, health, well-being, inclusion, and so on and so forth. So until we got something that everybody can understand. The third one is to continue to provide update on what is happening, the sciences, the key messages. As it's coming out from the EOC or Presidential Task Force, we also share with all the stakeholders. The last one is feedback mechanism for us to understand the reach and how they are utilizing these messages, the impact it's making, and more importantly, to further understand how to better support them where they are having challenges, and then get overall feedback to influence our policy at the national EOC. So, though we are challenged with the last one, because we know that M&E is still a big challenge, and we continue to work with stakeholders. I was just coming from one conference in Morocco, SBCC, Social and Behavioral Change Conference, and it's a global conference, and this was a big issue. And then we also met with some stakeholders who are working in this. I think over time, we want to thank Nigerian Airports and every other stakeholder that made sure that communication is part of this conference. I've been going to conferences, it's all about epidemiology and so on they talk about. But the fact that we're discussing this is something that we can build on in future. Thank you.
Okay, thank you very much for that. Thank you very much, Dr. Disu. I think, this 1.5 hours, there's been so much to dissect, so much to talk about. I think initially we started off with 2 examples of the social listening project done by Sydani, and also some of the work we did at Nigeria Health Watch in terms of debunking misinformation. And misinformation and disinformation, I think, is going to be part of us going forwards in any public health response. And we have to be front and center in knowing how we tackle that and getting in front of that before it spreads, and using the different platforms and tools to do so. And, importantly, as, Imabla mentioned, the very, very important role of the media and how public health institutes have to work with journalists, part and parcel of any response. How do you ensure that you build their capacity to accurately report, accurately as much as possible? I think Agri gave a very good example of how, sensationalism can actually influence how they report on news. People are going for clickbait and for, being the first to report. But that aside, the public health institutes have got to work with media going forwards. And we saw some great examples through Africa CDC, through the work with the Rwanda Biomedical Center, and also with NCDC, and how, working with the media ensures that the right message is communicated. Of course, also bringing in the very important role of CSOs. So I think, for us, having this side event and bringing health communications as a critical element of any outbreak response, we feel is very important. And I think many lessons were learned, in the different countries that we all come from, and how that was done at a country level. I think, in a way, there's almost a community of practice that we now build across the continent on how that goes forward, and, through the leadership of Africa CDC, how we go forward in doing so. So without further ado, I'd like to thank my panelists. Reaching out to all of them, was really great, because we were able to get a very diverse group of panelists to speak about the different issues. So, Imabel from Rwanda, Agri, who is from Pandemic Action Network, but I know you're from Kenya, and Dr. Benjamin, with leadership of Africa CDC. We're really, really glad we have such a great body now on the African continent, leading not just in communications, but across everything we've spoke about the past few days. And of course, Nigeria CDC speaking from a country level on the role of communications in a public health response. So I'd like to just join me in saying thank you to all of them, and also to the team that helped put together this side event, and to all of you also for spending this time with us. We look forward to hearing from you if you want to speak to any of the panelists individually, or even reaching out to our individual organizations to learn about the work we do and how you can engage with us even further. So thank you ever so much. We actually have refreshments outside, so good to sort of network and speak to other people, and also learn about what we all do in our different day jobs. So thank you once again for joining us today.